Welcome everyone to the webinar.
Good evening, everybody, and welcome to the webinar, Fertility Patients During COVID-19, What We Know So Far. This webinar is arranged by Fertility Europe with the cooperation of ESHRE. My name is Satu Rautakallio-Hokkanen, and I am the chair of Fertility Europe. The webinar is recorded, and the link to it will be later on Fertility Europe's and ESHRE's websites. At first, I would like to remind you that you can ask your questions via Slido. You can scan the QR code to join the event or go to slido.com and enter #FEwebinar as event code. You can leave your questions during the presentations, and we will then address them to the experts in the Q&A part of this after the presentations. Please also put in your questions to whom you are addressing it to. The COVID pandemic has had a strong impact to the whole world and also to infertility patients. The lockdowns closed clinics, queues and waiting times got long. We have very little data about what kind of impact the virus has on fertilization, fertility treatments, pregnancy, birth, or the health of the mother or the child. There are also many questions about the vaccines and vaccinations, about the timing, when to have the vaccine, and whether or not to have it. Patients are constantly pondering with these issues and trying to find answers. Tonight we have three excellent experts who will now share their knowledge with us about what is known so far. Kari Johansen starts with her presentation about vaccines and vaccination. Victoria Mail will share the recent data about COVID and pregnancy. And Edgar Mocanu will tell us the experience from the clinic's point of view. So Kari, please, the floor is yours.
Good afternoon and good evening. Can you hear me?
Yes, we can.
Thank you very much. And thank you so much for the invitation to speak at this webinar. So let me upload the slides. Can you see the slides?
Yeah, perfectly.
Yes.
Thank you very much. So in the next 15 minutes, I will share what is known about the vaccine production technologies, which vaccines we have authorized in the European Union, what vaccine recommendations we have so far, vaccine coverage that has been obtained, and a little bit about vaccine efficacy, which is before authorization during the clinical trials, and vaccine effectiveness, which is after authorization. And then I think there may be a great interest in vaccine safety, and there is some first data that I will end with. So, April last year, we knew that we would have 9 production technologies that could be used to develop COVID-19 vaccines. They're all listed here, and this is the publication published 9th of April last year. And we have reached so far since this first publication. And the technologies that have been used are the non-replicating viral vectors, and I will describe to you what they are, and the messenger RNA vaccines. I think you may have read a lot about them in the regular media. It's amazing how much detail media provides to every one of us. So I think everyone is now experts on messenger RNA vaccines, but we will go through them a little bit. So in the European Union, most vaccines are now authorized through the EMA, the European Medicines Agency. And we have 4. 2 messenger RNA vaccines developed by BioNTech in Germany together with Pfizer in the United States. And then we have the Moderna, a smaller developing country working closely to the NIH, the National Institute of Health in the US. They are both messenger RNA vaccines, and they have expanded through the United States, through Europe and the world today. Then we also have the non-replicating vector vaccines, and there are 2 of them also. The first one is developed initially at Oxford University, and then they linked up with AstraZeneca, and then by the vaccine company Janssen. There are also 4 more vaccines in what EMA calls rolling review. So they try to facilitate authorization, we will see how many of these will become authorized. Some of these are produced in Europe and others are produced both in Russia and China. But there are several developers that had to restart. For example, GSK and Sanofi Pasteur, which we are used to develop and produce many of the vaccines we use, they had to restart because the efficacy data was not strong enough. So a few words about the different technologies. This slide shows you how a virus up to the left is identified, and the messenger RNA or the genomics of the virus is identified and put into a computer, and then you can move on with that sequence that is called and make a vaccine. And in the end, you inject messenger RNA into the arm of whoever is going to be vaccinated, and the individual, the person who is vaccinated, make the protein that you develop an immune response to. So what are the advantages and disadvantages to these messenger RNA vaccines? So the advantages are they're very rapid to produce. I will come back a little bit to the variants, and you've read about the Delta variant a lot in the last 2 to 3 weeks. The messenger RNA company says it takes 3 to 4 weeks to develop a new vaccine, meaning that they have it in a small little vial, they have the initial vaccine, and then they have to expand it, of course, into the millions and billions that you need. They are viewed safe and non-toxic. They're non-infectious. They do not integrate into the human genome. The messenger RNA degrades within 2 to 3 days. And as I already mentioned, the antigen or the proteins, they are expressed within the cells in the muscle where we are vaccinated. They also do not induce any immunity. And this means you can go back with the same messenger RNA, but expressing different proteins. So that's a big advantage. The disadvantage is that we've never had any messenger RNA vaccines licensed before, and booster shots may be required. And the first data really suggests that we will be needing vaccine boosters late autumn, or hopefully not before that. Also, stability is an issue, and a lot of research has gone into that. And storage has been an issue. I think many of you know that they have to be stored at -70 initially, and that was a difficult task to handle if you move out to a home for elderly people and you have to carry dry ice to manage that. The second big group where we already have vaccines from are the non-replicating vectors, and it is a virus that you probably have heard of many times before, adenovirus. And they have incorporated parts of SARS-CoV-2 or the COVID-19 virus into the adenovirus, and they express these red blobs that you see in the picture here on the surface. That's the spike protein. And all the vaccines we have today focus on the spike protein. You see there are many other proteins also. Viruses are like balls. They're very defined in their structure. But vaccines that we have available to us now are focused on the spike protein. So what are the advantages of the adenovirus vectored vaccines? Well, it's a well-established technology. It induces both strong B and T cell immunity. B cells produce the antibodies that you have heard of. They're also very thermostable, and it's easy to scale up, and they are rather cheap. And I think you may know that AstraZeneca has promised to sell and distribute their product widely, both production and through WHO, the COVAX mechanism, to a very low price, at least in the initial phase of the COVID-19 pandemic. The disadvantage is the previous, if you've been exposed to this adenovirus, you may develop antibodies to it. And that means that you may develop less antibodies to it. And therefore, you may have read that AstraZeneca have been in contact with other producers having similar technology. Whether this will come true or not, it's very difficult to say. The third group I wanted to touch base on are the protein subunit technology. These are much more like the vaccines we are very used to, but none of them are authorized yet. And there are two companies far ahead, Novavax, and they are expected to file with the European Medicines Agency in Q3, so somewhere early autumn. The studies have gone well, and they have been in South Africa and I think in Brazil as well. While Sanofi GSK, they had to restart. They didn't have a good enough efficacy, but they now have a good candidate. They've restarted their phase 3 trial, and maybe by the end of the autumn we will have a product from them. So what are the advantages of them? Well, it's well-established technology. It's suitable for people with compromised immune systems. And that is very important because we do have many with compromised immune systems. There are no live components, and they're also relatively stable. But they are a bit complex to manufacture. And to stimulate a good immune response, you need some kind of adjuvant. And you may also need booster shots. Which we shouldn't be too depressed about, because if you think of the pediatric programs, polio, for example, all of us listening in here, we've had at least 5 shots of polio in our lives. So that is not an issue, but it does take some organization. So where are we now on who can get vaccinated? So the regulators, they decide on the indications, who can get the vaccines. And for both BioNTech and Moderna, the large regulators have said that there's data enough to recommend it from 12 years of age. Not all public health institutes have done that. In Europe, there is, for example, Germany has recommended from 12 years, Denmark just a few days ago, Poland has, but there are also many that are waiting for more data to become available. We should remember that 8th of December last year is the first day anyone was vaccinated with COVID-19 vaccines. So it's a very short time, and I'm very happy that many are conducting studies, so we will know a lot about them. We already know a lot, but we need to know even more. The other 2 are authorized from 18 years of age. In the blue circle, I'd like to, for the first time, address pregnancy and pregnant individuals. And we will hear more in the next presentation that pregnant people are more likely to get severely ill from COVID-19. So if you are pregnant, you can receive the COVID-19 vaccines. And the general rule is after gestational week number 12, but it can be offered earlier if there's a need, if the mother has a risk factor, for example. I also want to mention that there are several clinical trials still ongoing. First, we start with the children. So we have lots of children and they are a reservoir for the virus. And one day we need to start vaccinating them, just as we've done for measles and many other infectious diseases. And the companies are going down in a stepwise manner. So they started with 5 to 11 years, 2 to 5 years, and then down to 6 months and 2 years. And then to cover the first 6 months, you will have, or hopefully we will have maternal antibodies protecting the infant initially. I also want to mention that there are some very interesting studies being done. And UK is carrying a very heavy burden on many of the studies. In Oxford, there's a mix and match study. So you can be, for example, vaccinated with the Oxford vaccine first and then the Pfizer vaccine, or the opposite. And then antibodies are studied, and what we call reactogenicity, if you get a sore arm or more fever if you start mixing products. There's also a lot of work on a third dose. So you have to prove or show that a third dose is needed. And this may be needed because of the new variants. They're also combining with influenza vaccine that I forgot to put on the slide. And they're also want to try to understand if many of us have had COVID in the last year, so have I. And the question is one dose enough for these individuals? And France has taken such a stand that one dose is enough. So where are we on vaccination in the EU? I think many of you know that the European Commission is procuring vaccines for all EU countries. And we have, if you look up to the right, 54% of the EU population overall has received the first dose, and 31% has received 2 doses. And on the map here to the left, you see the 2 countries that are darkest, Iceland and Finland. They have come the furthest in the vaccination programs. And here is the initial target, around 70%. I think that will rise, maybe even above 90%, with the variants now being so important and slightly evading the immune response. So a few words about vaccine efficacy and effectiveness. Against symptomatic infection, meaning fever and all the other symptoms, the different products provide protection somewhere in the range between 64 and 94% in the pre and post authorization studies. And against asymptomatic infection, meaning that we are just carriers and do not and still can transmit, it's somewhere between 89 and 92. And I added a slide from last week, which is something that I just dived straight into when the data came. It's by Julia Stove, working at Public Health England. They developed very good immunization registry, and they have compared in the circles here vaccine effectiveness against hospitalizations or severe disease. For the Alpha variant, which is the one that was identified in Kent in the UK initially, and the Delta variant that was first identified in India. And what I want you to look at is at the Pfizer vaccine, dose 1 and 2. They're both above 80%, slightly worse after 1 dose. So UK is really advocating 2 doses. And this is also true for the Delta variant. And especially if you look at the AstraZeneca, they are around 71% efficacy. This is effectiveness, I'm sorry, after post-authorization, after dose 1, and 92% after dose 2. So a few slides about safety issues. So in general, these vaccines, they have been, you saw, it's hundreds of millions. Probably if you include also the Chinese vaccines, there are several billions of individuals that have received the COVID-19 vaccines. And in general, they have been incredibly safe. There are a few signals that are being investigated, and they are very, very rare, less than 1 in 100,000, and possibly the myocarditis signal may be 1 in 50,000 in younger individuals. And there are formal studies ongoing besides the routine reporting. And for the myocarditis, because the children and adolescents are sort of next in line now to be vaccinated, it will be discussed extensively this coming Friday at the expert committee in the United States, where they recommend vaccination. I wanted to say something about safety during pregnancy. On the 17th of June, so I'm glad we have this meeting now, the first publication came out, and it comes also from the United States, where they have built a very nice database on the reporting, the regular reporting. And the title is Preliminary Findings of Messenger RNA Vaccines in Pregnant Persons. So it's only messenger RNA vaccines given during pregnancy. And they've looked at individuals vaccinated from December to February, and they have this vaccine safe pregnancy registry in the United States. And it's about 35,000 individuals, so quite a good number behind these numbers. And the data in general looks very similar to before COVID-19 pandemic broke out. So that's the main message. But if you dive into the article, it says that injection site pain is slightly more common in pregnant women. And out of the 4,000 women that they've studied, 800 have completed their pregnancy. So this is very important. You need a 1-year follow-up to feel comfortable. And 712 have resulted in live births, and 115 have resulted in pregnancy loss. And as far as I understand, this is within the normal range. There are no neonatal deaths. There are some preterm births in almost 10%, and some also small for gestational age. So the authors conclude no obvious safety signals among pregnant persons who received messenger RNA COVID-19 vaccines. However, more longitudinal follow-up, including follow-up of large numbers of women vaccinated earlier in pregnancy, is necessary to inform maternal, pregnancy, and infant outcomes. So with that, I'd like to end and say thank you very much. If you would like to read more about the surveillance that is needed on many levels, we wrote about it in the journal Eurosurveillance under the title "No Country or Continent is on its own in the ongoing COVID-19 pandemic." So with that, I'd like to thank you.
Thank you very much, Kari. This was a very interesting and comprehensive presentation. I'm sure there was a lot of information for most of us that we haven't even heard before, so thank you so much. Our next speaker is Victoria. So Victoria, your turn.
Hello, can you see my slides?
Yes, we do.
Just my
Or
slides, or
actually
do you
not,
also see my notes?
yeah, we see both.
We see both. Oh, I wonder if I can just show you my slides.
You can choose what you share in the sharing panel. Below the play button, there is a drop down, and there you can choose which application you share.
Aha. Do you see now only my slides?
Yes, we do.
Brilliant. Great. So hello and thank you for inviting me to speak today. My name is Vicky Mail and I'm a lecturer in reproductive immunology at Imperial College London. And that means that I'm particularly interested in the immune system in pregnancy and in vaccination in pregnancy, although what you've asked me to speak to you about today is COVID-19 infection in pregnancy. And of course, knowing the risks of COVID-19 infection in pregnancy is very important before we start to consider vaccination in pregnancy, because how risky COVID-19 infection is will inform our decision about whether we should offer the vaccine to pregnant people, or maybe even we should prioritize pregnant people for vaccination. So today, I want us to find the answers to 3 questions. What kinds of outcomes do we see when people catch COVID-19 when they're pregnant? Can the COVID-19 virus, which is SARS-CoV-2, infect the placenta? Can it infect the baby while it's in the uterus? And finally, the mother will raise an immune response to the virus when she's infected. Do we see this helping the baby at all? So, let's start then with the outcomes. And I guess the logical place to start is the first trimester. So if you catch COVID in your first trimester, is there any effect of that on pregnancy? Are you likely to lose the pregnancy? Now, this hasn't been an easy question to tackle, partly because miscarriages are very common anyway, affecting about 15% of all pregnancies, and partly because COVID can be asymptomatic. So it's not always obvious when someone presents having a miscarriage if they've got COVID or not. But nonetheless, 2 studies did try to look at this. So this one, there we go. This one looked at 100 people who had a miscarriage paired with 125 people who had ongoing pregnancies. And they matched the 2 groups for how many weeks pregnant they were. And they screened all of them and found that about 10% were positive for COVID in both groups. That might seem high, but this was at the peak of the first wave last year. And there was also no difference between the groups in the proportion of the people who had symptoms. So that suggests that we don't have an association either of the COVID-19 virus, SARS-CoV-2, or of COVID-19 disease, illness, with pregnancy loss. This paper took a slightly different approach. Basically, it was seeing if miscarriage rates differed between the period in 2020, when COVID was very widespread, compared to rates in the equivalent period in 2019. And they weren't. So from both of these papers, it seems that COVID isn't associated with miscarriage. And we also have another study that followed up 29 people who were infected with COVID in either their first or their second trimesters, and then they recovered. And this study took a look at how things turned out for their babies. And these babies whose mothers caught COVID early in their pregnancy but then recovered did all seem to be fine. So early in pregnancy, COVID so far doesn't seem to be problematic. But unfortunately, this doesn't remain the case because we do start to see problems arising later in pregnancy. Now, I don't want to alarm anyone unnecessarily because lots of people who catch COVID later in pregnancy are just fine and their babies are fine. But there can be serious problems associated with catching COVID in the 3rd trimester. So if we look at people who have COVID and we compare those who are pregnant to those who are not pregnant, we can see that pregnant people are more likely to need intensive care, invasive ventilation, or ECMO, which is another way of helping people breathe when they're having difficulty breathing. And this is the kind of data that has led some countries to say that pregnancy itself is a risk factor for severe COVID, and that pregnant people should be prioritised for vaccination, just like people who have other conditions that would put them at higher risk of severe disease. So that's the pregnant patients themselves. But in order to have an idea of the impact of COVID-19 on the baby, obviously we can't compare pregnant and non-pregnant COVID-19 patients, because then your comparison group doesn't have a baby involved. So what we need to do is compare those people who are pregnant and have COVID with those people who are pregnant and don't have COVID. And when we do that, we can see that if you catch COVID while you're pregnant, it's more likely that your baby is going to be delivered early. And that seems to be because doctors are choosing to deliver the baby early to try and save the mother, rather than because people are going into labour early spontaneously. They're also, these people who catch COVID in pregnancy, more likely to need intensive care or die, but that's not really surprising because don't forget we're comparing them to people who don't have COVID. And if we look then at the babies, their babies are more likely to be stillborn or to need intensive care. Now, it's worth saying that not all studies have identified this increased risk of stillbirth, but the paper that I'm taking these figures from is a synthesis of all the evidence that's been published so far. And it's found that taking it all together, it does seem that your baby is more likely to be stillborn if you catch COVID in late pregnancy. So COVID in early pregnancy doesn't seem to be associated with any increased risk of problems. But in later pregnancy, after about 28 weeks, it's associated with an increased risk of these various quite serious problems. And we didn't get into it before in the vaccination talk, but that does actually inform when we should give the vaccines, because at the very least, we would ideally like people to be fully protected by the time they get to this dangerous period after 28 weeks. But continuing to consider the potential consequences of COVID infection during pregnancy, let's move on to the second question that we wanted to tackle. Can COVID infect the placenta? And can it cross the placenta to infect the baby? Now, early on, we had really quite a lot of reports of newborns who got a positive COVID test on a nasopharyngeal swab. But we couldn't really be sure if those babies had been infected in the uterus or shortly after birth. So we started to take some other approaches. And those approaches were looking for the virus in the placenta, cord blood, and amniotic fluid, places that really tell us that it was there before the baby was born. We also started to see if babies had made their own antibody response to the virus, which again tells us that the virus had actually got into the baby. And we can tell this because there's a kind of antibody called IgM that can't cross the placenta. So we know if we see IgM in babies that they must have made it themselves, and therefore they must have been infected with the virus themselves. And this graph summarizes all the studies that have been published on this topic up until last summer. Now, of course, a lot more has been done since then, but actually the newer studies are roughly in line with what's shown here. So this acts as quite a nice summary that I think we can still get something out of. And what it tells us is that intrauterine infection happens, but it's reasonably rare, only a couple of %. It's not common, but it does happen. And to understand why this might be, I want to take a moment just to think about how viruses cross the placenta. There are really two places at which this could occur. So here we see these finger-like projections of the placenta, which are called villi, sitting in the pool of the maternal blood, and they allow oxygen and nutrients to cross the placenta, to go into the baby, and waste products to come out of the baby for the mother's blood to take away. And viruses in the blood might be able to infect the cells of these fingers. The second place at which we might see the virus crossing is here. These cells of the placenta invade into the lining of the uterus, and that opens up the blood vessels to make the pool of blood in which the fingers sit. That's helping the baby again to get its nutrients, its oxygen, and to get rid of its waste products. And the viruses that might make it into the lining of the uterus can cross the invading placental cells here and up and sort of make their way up into the finger-like projections and then across the placenta. And it's worth saying that most viruses actually can't do either of these things. Part of the placenta's job is to protect the baby from viruses, and it mostly does that really well. But in any case, for the virus to get to either of these locations, given that it starts off in the lung, it first has to get into the blood. But actually, most COVID patients don't have virus in their blood. So in this study, only about a quarter of people did. And actually, the chance of you having virus in the blood depends on how ill you are. So this study found that people who are in intensive care, about half of them had virus in their blood, but only 13% of people who had symptoms but were not ill enough to be hospitalized did. So we're only talking about a subset of patients who are at risk of the virus getting into the placenta, and that risk depends on how sick you are. And then from the blood, we have to get across the placenta. And the first step of that is going to be infecting the placenta. So we can ask ourselves, does the placenta have the right molecules on it that would allow the COVID-19 virus to infect it? Now, the main molecule that a cell needs in order to be infected by the COVID virus is the angiotensin receptor ACE2. This is hardly expressed at all at the end of pregnancy, which probably explains why we don't detect a lot of placental and transplacental infections at birth, which is obviously when we find it easiest to look. But what I think is worth noting here is that it's a lot more highly expressed early in pregnancy. So it may be that these infections are more common early in pregnancy, albeit that they are more difficult to detect. So finally, another question that we might ask is, even if the virus doesn't get all the way across the placenta and into the baby, can it have an impact on the placenta? Maybe even just the immune response could have an impact on the placenta. And there have actually been lots of reports of placental pathology associated with COVID infection. But the problem is that most of them didn't have a proper control group of placentas from people who didn't have COVID. And some of those that did, they didn't have the person making the judgment about whether the placenta was pathological. They told those people which were COVID placentas and which weren't, which might have biased their judgment. So looking only at those studies that had a control group and where the person making the judgment didn't know which placenta was in which group, we really come down to 4 studies. And here, blue is no change, red is an increase in the pathology, and white is the study didn't look. So we see that COVID infection isn't associated with inflammation of the placenta and the membranes, which we call chorioamnionitis, which is really good because chorioamnionitis is often associated with preterm birth. And it's not associated with malperfusion of the placenta, which means not enough blood flow, where the blood's coming from the maternal side. Although some of these studies did report not quite enough blood coming from the fetal side. But what we see most consistently is an increase in clotting in that space that I told you about, where the finger-like projections dip down into the mother's blood. I'm telling you that by saying that we have an increase in fibrin deposition and thrombosis. So basically, we have this somewhat increased tendency to clot, which is actually very similar to what we see in other organs in COVID. Now, to be clear, although these studies were seeing these pathologies more often in the COVID cases, they weren't seeing it in every case. So similar to what I told you about preterm birth and stillbirth, it's not definite that this will happen if you catch COVID while you're pregnant. It's just that it's more likely to happen. So from all of this, I think we can agree that we'd probably prefer to avoid catching COVID-19 during pregnancy. Although to be fair, of course, I think everyone would probably prefer to avoid catching COVID. But is there any upside to catching COVID? And I guess the upside that I'm thinking of is we know that antibodies can be transferred across the placenta. So if you catch COVID and make antibodies against the virus, will they go across the placenta and protect your baby when they're born? And the answer to this is yes, but with some caveats. So here we're looking at a kind of antibody called IgG, which we do expect to go across the placenta. And you can see from the two leftmost comparisons, which are called RBD and N, that we do get IgG going across into the baby, but not IgM, that I already mentioned doesn't cross the placenta. So far, so much what we expect. But here's the interesting thing. So as a comparison in this study, they also looked at how well antibodies against flu went across the placenta. And that's the bars on the right that say HA. And they found the antibodies against flu were going across the placenta very efficiently. And you can tell that because the kind of bar that shows the average is more than 1. That's actually how good we normally are at transferring antibody across the placenta. We see a value of more than 1 in terms of efficiency. But for COVID, that antibody transfer is less efficient than normal. So although we do transfer some antibodies across the placenta to the baby, it works less well than usual for COVID. And it's also worth noting that if you get vaccinated against COVID, the vaccine sort of raised antibodies will go across the placenta, and they seem to go across the placenta more efficiently than the antibodies that are raised to natural COVID. So to summarize, from the evidence that we have, it seems that COVID in early pregnancy is not too harmful, but COVID in late pregnancy is associated with an increased risk of these various poor outcomes, including preterm birth, the baby needing to go to intensive care, and potentially stillbirth. Placental infection and transmission into the baby do occur, but they're not that common, happening only a couple of % of the time. Although I have to say that's still more common than I probably would have predicted if you'd asked me to predict this, you know, well, this time 2 years ago at this point, I guess. And finally, the antibodies that your body makes against the COVID virus, SARS-CoV-2, do cross the placenta, which may give your baby some protection against COVID once it's born. But that transfer of antibodies happens less efficiently than we would expect. And so finally, I'd just like to thank my team and my funders, and I'll hand over to the next speaker.
Thank you very much, Victoria. You have given us information that the patients really are looking for at the moment. And there are some bad news, but also good news. And I think there are more good news than bad ones. Thank you very much. And the next speaker is Edgar Mocanu, and he is going to show us or tell us about the clinical point of view of COVID-19. Edgar.
Good. I don't know if you can see me. Good afternoon,
No,
everybody.
we can't.
Okay.
At least I can't see.
Can you hear me? Okay, I have a small technical issue with the slides, so I don't know if Titia can put them up. I'm happy to move them if I can. The GoToMeeting app is acting up. So can I receive the second invitation again to show them up? My apologies for this.
Titia, you might be able to help him.
Yes, I will. I am sending the request now.
Show my screen. Good. That looks good. So
yeah, we see your screen.
Okay, so I need to decide. You can see all my screen, and I'm just going to try to make this large. Can you see just my presentation?
Yeah, we do.
Excellent. Thank you all, and sorry for that. Working on Apple sometimes creates a bit of a challenge. A pleasure being here. This is, I believe, a very interesting and exciting opportunity for patients to understand more about vaccination and about pregnancy. So what I will be covering is the early part. It's before getting pregnant. And ESHRE has done a bit of work in terms of how to maintain services open and how to adapt them to help all patients across Europe and, in fact, to a wider extent globally. But I believe this is a matter of mutual understanding, because there's no doubt that patients are frustrated, as are practitioners. So I'm planning to cover the following areas today. I have a disclosure of doing some work with different international organizations, but the cover is the COVID-19 effect. Is treatment, fertility treatment, a risk? What is expected in terms of changes? And my suggestion that you, as us, the practitioners, adapt to change, seek support, and see the positives out of this pandemic. So usually services understand the patient perspective, propose changes to reflect this perspective, implement those changes, audit the impact of change, and propose improvements. And this process of continuous improvement has, I believe, significantly been augmented by the COVID-19 required adaptation. So I believe that ART services will be well ahead in the next few months compared to the maybe slower pace last year and the slow pace of progress in the last years. So is treatment a risk? Slight coverage of these topics in a previous talk, but just to cover firstly male reproduction. I will not go into detail, as I assume that vast majority of the audience are patients. So I will not go into detail of this paper. This is a paper from Italy that looked at males that had acute COVID-19 infection, and there were 43 patients, and basically showed that about 11 men out of this 43 had semen impairment, with 8 of them having no sperm whatsoever. So there's no doubt that COVID-19 causes an impact upon sperm production. And for this reason, the French Society of Andrology suggested that one should actually wait for a little while before trying to conceive if they had acute COVID-19 infection. And this, of course, reflects upon desire to start some form of assisted reproduction. So the summary in males is, to date, there's no evidence to suggest one should avoid intercourse during the COVID-19 pandemic. There is no convincing evidence, despite the fact that the disease itself affects spermatogenesis, affects the sperm production. There's no convincing evidence that the virus is present in the ejaculate. And the suggestion that males diagnosed with COVID-19 should avoid IVF ICSI for 3 months. And this is the duration of new sperm being produced. So if the sperm is severely affected, the new wave of good sperm will take approximately 72 days. And the reason for that is the disease burden. The male will be affected, as is the female, of course. So you could be very sick. You could have fever. General state of health is poor. And depending on the severity of the disease, some might even need to be ventilated. But also because the sperm production is affected and some hormonal changes occur at the same time. What about reproductive tissues? So this is just to show you how advanced research is, where you can search databases and look and identify if certain receptors are present on different types of tissues. So for example, here in the blue boxes, it shows that the receptors for SARS-CoV-2 are not co-expressed. They're not both together on ovarian tissue, for example. And people were then interested to find out if the viral RNA can be identified in the follicular fluid if a woman is COVID positive. So let's say that an IVF unit does a collection for example, a cancer patient that has to go through the treatment, and she might happen to be COVID positive at that time and might even have the disease. And when the follicular fluid is aspirated to identify the egg, can RNA from the virus be found in the follicular fluid? And there's no evidence that the RNA is present either in the follicular fluid or, shown in Spain here on the bottom right by a group of Vacena, even in the oocyte, they could not find the evidence of incorporation of the virus in the oocyte in the female egg, which is very good news in terms of assisted reproduction. So the conclusion for females is the oocyte does not appear to have the entry factors called receptors that facilitate cell entry for the SARS-CoV-2 virus. And this suggests the oocyte might be protected against SARS-CoV-2 infection. And it is obviously protected in vitro, but one would assume it is also protected in vivo, meaning in vitro in the laboratory, in vivo in the female body if she decides to get pregnant actually. And what about the human embryo? And here you can see the two important receptors, the ACE2 already mentioned, and this protein called TMPRSS2. And the cell has to have both those present. And although I know that this might look very science fiction, just focus your attention on the right-hand side where you see this heat map. Pardon me, I'm going back. And what this heat map shows is that it looks at the oocyte, the early embryo after fertilization, 2 cells, 4 cells, 8 cells, and morula, and then the blastocyst, which is a day 5 embryo that has an inner cell mass and so on and so forth. A bit complicated, but basically you can see here ACE2 is one of the receptors and the TMPRS is the protein. And you can see that one is present, the other one is absent, and only about here you can see both of them present, which is at the stage of day 5 embryo. So basically, the embryo in its early stages of development, as well as the oocyte, do not have both receptors. So it's extremely unlikely that the virus can integrate into the early embryo. Yet, from day 5 onwards, there appears to be some expression, but it's only in the outer part. T stands for the trophectoderm. It's the outer part of the embryo, which forms the placenta, and it's mainly there, but not in the inner cell mass in significant amounts. The inner cell mass is this column here, and there is just a yellow, and you can see yellow is very, very low expression. For this reason, some people suggest that maybe if one needs to freeze the oocytes, it's better to freeze oocytes and embryos before day 5. So in conclusion, human factors, the entry factors gene are only expressed from day 6 onwards of the human embryo development. The pre-implantation, which is up to day 5 or 6, those embryos are unlikely to be susceptible to SARS-CoV-2 infection. The post-implantation early human embryos, because they express, they could be susceptible to the infection, and the mother is at that time infected, she could potentially pass the virus to the developing embryo. But all this data that I've showed you initially on the RNA expression is not fully validated yet, so we have to wait human studies. So what does it mean in terms of patients accessing services? I think services have adapted significantly, and ESHRE has produced a lot of guidelines and recommendations of how to do that. But basically, access has been curtailed, at least in the beginning, with reduced number of patients accessing care, needing for social distancing, needed for cleaning, and so on. The teams of staff providing care had to be reorganized, so a smaller number of staff to have a reserve of staff in case somebody becomes sick, so to ensure continuation of the service. This obviously have created delays in starting therapy, and some therapies have been severely affected. And here I'm thinking about patients that will require travel for donor therapies, for example. Yet, I believe that vast majority of clinics have done a very good job in organizing triage questionnaires that basically divide patients into no risk, maybe infectious, or high risk, and do not access treatment. So this is what this graph depicts. If the staff or the patients or the partners are asymptomatic and they respond negative to all the questions, and by the way, these graphs, you don't need to write down anything. If you want to refresh in your memory, please access the ESHRE website, and they're all there. And If the triage is negative, these are scenario 1. We can include these patients. We allow them to have treatment. If staff patients might have mild or non-specific symptoms, and the triage might say maybe contact with somebody, then we have to test either with RT-PCR or antigen testing. And here, if the test is negative, we allow continuation of treatment, yet we're continue triaging patients every time they come back. Or if staff or patients have symptoms or a previous COVID negative positive test, or the triage is positive, or if they test positive in this box here, then we will delay treatment for 2 or 3 weeks. Staff have to be also assessed. Both patients and staff work together towards the continuation of services. So in case of staff, if they're vaccinated for COVID-19, they could start working, and if they're not vaccinated, then they could have a SARS-CoV-2 test performed every 2 weeks. With negative test, continue working, positive test, occupational health advice, and self-quarantine. And in between those moments when they attend, they could have, and they should have, a triage questionnaire and use the ACT diagram, which I've just shown you, which is the previous slide. Equally, patients undergoing treatment will follow very similar procedures. So in the 2 weeks prior to the start of IVF, patients that have either had previous COVID-19 disease or have antibodies after the disease or have been vaccinated belong to the standard procedure green channel, saying these people are less likely to be infectious, and so let's allow them the treatment. If they didn't have the disease before, if they don't have antibodies, or they have not been vaccinated, those patients will require a test for SARS-CoV-2, either PCR or antigen. And if the test is negative, they enter the standard procedures. And at each step, for example, next step will be at the start of ovarian stimulation, the triage questionnaire, and acting accordingly. We'll have 3 options: triage questionnaire negative, start the procedure or continue the stimulation. In doubt, test, or if questionnaire, the triage questionnaire is positive, test for the COVID. If negative, continue treatment, or if positive, postpone treatment. And if they test positive from the beginning, 2 weeks prior to the start of treatment, postpone treatment till for 3 or 4 weeks. And you can see the trigger for egg collection or OPU or progesterone start for FER follows the same protocol. An interesting aspect, which I do stress out a bit later, is the follow-up. And vast majority of ART services will actually see the patient, and unless the patient has a positive test, they will not see the patient for quite a while. So it will be wise for IVF units to have a follow-up questions after transfer, maybe 2 weeks after transfer. It will be very nice for patients to volunteer the information to a simple question. Have you contacted COVID from the moment we last saw you for transfer up to 2 weeks after? And if you did, maybe just to observe what happens with the pregnancy if you are pregnant. In this way, we can learn more about the very specific question related to early embryo impacted by COVID-19. So I have 2 or 3 slides here that try to look at the bigger picture. So I think that the COVID-19 pandemic is one of those parts where we recognize that life on Earth is still dangerous. The lockdown had a significant impact upon human reproduction. It forced us to stay indoors. It increased stress. It sometimes made people put on weight. It allowed people to maybe indulge on alcohol and substance use. Some people exercise less, but it is true some people exercise more. And on a positive side, maybe less pollution is good for reproduction. But in terms of services, I think if you remember that accelerated progress, and one of them is the remote access to care. And patients now have far more access to care using tools like the one we're using now, which is online chatting. Simplification of treatments, as I will show you. And one thing that was negative was obviously the lack of travel, but now Europe is opening, so travel opening, and this obviously will remains to be seen if costs are rising in terms of travel, and restrictions will be in place when patients wish to travel. So I see that the ART adaptation, the consultation now is mainly online. I think that's very handy for the patient. You, in the comfort of your own home, without having to travel, without having to wait, without having to wonder where to park, you can have a full consultation. The treatment plan and treatment could all be organized online, including the prescription. The stimulation monitoring will require fewer visits because this adaptation says see the patients only for 1 or 2 visits, and I think this is far better for patients. And then the triage and testing is streamlined, as I've showed you, and I think the environment in clinics is safer. There's less patients, less risk of contacting the disease, and I believe overall the access to care somehow is rebalanced in making things better for patients. So I suggest that we start seeing past the pandemic. The severely restricted freedom has resulted in accelerated adaptation. It's reassuring to know that there's no evidence that the virus has any long-term impact, but we have to acknowledge that patients are suffering due to limited access in certain places. I think in the future we need to encourage mutual understanding between the services and the patients. The patients and staff acknowledge the need to respect rules. They should be available for screening and maintain awareness wherever they travel. They must adapt to new circumstances and I think help each other work together. So I see the opportunities as please have patience, care will slowly return to normal, and I put a question mark, hopefully improved. Be militant, make your voice heard. If more and more restrictions remain, please say that fertility is something that governments need to support and open access to. Support each other, patients and staff. Avail of emotional support. I think that's important. There's no place for staying at home if you find you can't cope. There is care available out there. Please avail of it. Ring the clinic, say, do you have a counselor? Can I see somebody that can advise me online? Thank you very much. Furthermore, there's no reason if you don't have IVF but you would like to have some fertility investigations, there's absolutely no reason not to see a specialist and say, I'd like to start the investigations, please help me. And I think patients have a significant role now to help improve practice by follow-up of positive cases where practitioners can learn from the patients that have had COVID while just becoming pregnant. I'd like to say thank you to Fertility Europe and thank you to ESHRE for inviting me, and thank you for being here, and I look forward to any questions you might have. Thank you.
Thank you very much, Edgar, for sharing us the clinic and clinicians' point of view. And I can assure you that the infertility patients really appreciate all the effort that the clinics have been doing under these very challenging circumstances. Thank you. So we have a few questions here. Maybe we start with the question to Edgar. So, if a patient is undergoing IVF, is it safe to take vaccine whilst doing the procedure? First or full dose, how long is the wait time before transfer?
Yes, obviously this is a very important question, and I might just draw your attention to the very first talk that discussed when vaccines can be administered in terms of age, but also the second talk that discussed impact of disease in early pregnancy. So currently we have no information on the impact of vaccination and early embryo development. And if we have no data, we somehow have to be cautious. in the sense that ideally the scenario will be you are vaccinated fully and then you start the treatment, because in that case you have the certitude that vaccination is in, antibodies have formed, you should be protected to 96% efficiency, as we've seen in the first presentation, and thus when you start the therapy, there's no need for further boosters or anything else. So I think at least my personal advice will be have the vaccination first and then proceed with treatment.
Great, thank you. And may I ask Victoria and Kari also to open your cameras, so you might also give some comments. Do you have any comments to Edgar about this question?
I fully agree. It's better to be vaccinated before if you have the opportunity to do that. If there's vaccine available in your country, we've been through a long period of lack of vaccines, and I don't know how the fertility clinics have been prioritized in different countries.
I don't know, Edgar, if you know better, but I haven't heard that in any country people going to treatments have been prioritized with vaccine. Have you heard anything? Yeah,
no,
probably
I
not.
haven't. No, and vast majority of countries vaccinate mature adults as opposed to the 30-year-olds now. So I think there'll be a few months before vaccination will be offered to the 25 to 35 to 40-year-olds. Yes, but obviously if couples are having treatment now, there's no reason not to have the treatment. But if they're offered the vaccination, they should prioritize taking the vaccination, delay the start of the treatment, and once they're fully vaccinated and antibodies had an opportunity to form, immediately start the treatment.
And perhaps also not have the longer period between the two doses. Some countries have had WHO is recommending 6 weeks between the two doses initially, while the manufacturers of the mRNA vaccines recommend 3 or 4 weeks. And it's probably a good idea to go for the shorter period.
Or have the Janssen one, which I understand it's still one vaccine, one dose. Is that correct?
It is. But I think it's mainly the, I try to read up on the recommendations, and I looked in the Nordic countries and I looked in the US. US only mainly has the mRNA vaccines, but they do have Janssen. And here it's also the mRNA vaccines being used where I'm sitting in Stockholm.
Thank you. I think this might be for Vicky. Can asymptomatic COVID affect my pregnancy?
Yeah, this is a really interesting question and one that's not very easy to answer. So I showed you some data that suggested that asymptomatic COVID early in pregnancy doesn't seem very likely to cause loss of pregnancy in the same way that symptomatic COVID early in pregnancy isn't likely to cause loss of pregnancy. The really big studies that we have about what's going on with COVID towards the end of pregnancy are mainly to do with symptomatic COVID. And the really bad outcomes tend to be people who are very ill with COVID. However, we did recently have a study in the UK that when people go to give birth in the UK now, or in fact into hospital for any reason, they get swabbed so we know if they've got COVID and we can treat them appropriately. And they looked at the data from an entire year's worth of people going into hospital to give birth, and they just divided them up by whether they were had a positive swab or a negative swab. So they didn't ask, do you have symptoms? They just asked, do you have a positive swab? And actually we did see some less good obstetric outcomes even with people who, even when we just divided up people like that. So it's possible, but the evidence for bad outcomes when COVID is asymptomatic is not nearly as strong as the evidence for bad outcomes when COVID is symptomatic.
Okay, thank you. Maybe the next question. Hi, I am 25 weeks pregnant, 1.5. Oops, lost that one. 1.5 months before my pregnancy, I had COVID. I was sick, but not seriously. How high is the risk I get COVID again and then get very ill?
We do actually have some data that speaks to this, not to do with actual illness, but we have data that looks at how strong the immune response to COVID is in pregnant people if they got the vaccine compared to if they got natural infection. And that data tells us that you're much more protected against COVID if you get the vaccine compared to if you had a natural infection. Now, for someone like you, obviously, it's difficult to extrapolate from population data to one person, but what we would say is that you're almost certainly more protected against COVID than you would be if you hadn't had it at all, but less protected than you would be if you had the vaccine.
Okay, thank you. And then there's a very interesting question, probably to Edgar. Do we already see IVF treatment effectiveness being negatively affected by COVID and or COVID vaccine, probably?
We don't have any data. We have to remember that it takes 9 months, 12 months for data to emerge from any country. ESHRE collects data, but we're at least 2 years behind in terms of collating it, publishing it, so we will not have data for at least 2 years. In terms of the only place that one will find data probably will be individual clinics. So one thing is to think about, are pregnancy rates affected by the COVID, and there should be no reason why pregnancy rates will be affected by COVID, because physically the likelihood that somebody with COVID has IVF treatment is minuscule, nobody basically. Clinics are highly selective, so they will not allow people that have COVID to go in. But there's no reason to believe that patients that attend and have no COVID will have a lower pregnancy rate than before. Of course, there will be less patients treated. That's a different story. Yeah.
Mm-hmm. Yes, Vicky?
So it's worth saying that if we're prepared to look at data from the United States of America and not just Europe, a couple of clinics have published data that looks exactly at this. There's one that's published in peer-reviewed journal by a clinic, and it looked at people coming in who were either vaccinated, not vaccinated and had never had COVID, or not vaccinated but they'd had COVID. And it looked at the rates of chemical pregnancy and clinical pregnancy. Obviously, those people haven't got all the way through their journey yet, but looking at those kind of early indications of how well people get on, it seems that it doesn't matter if you've never had anything to do with COVID, if you've had the vaccine, or if you've had COVID and recovered. And there was a second study that also looked at unvaccinated versus vaccinated people and found something quite similar. Individual clinics, small studies, but really relevant to these kinds of questions.
Thank you, Vicky. I think there's a very interesting question to Edgar also about male fertility. So do vaccines have any immediate effect on male fertility similar to COVID itself?
Unless Vicky knows of published studies, my answer will be very unlikely that vaccines will have an effect. Yes. As said, we have 6-7 months of vaccination, and remember that the vaccination was offered to people in their 60s and 70s and 80s in the beginning. So to see the impact of vaccination, you will need to look at a population in their 20s, 30s, and 40s, and then do those studies and assess. Furthermore, if you paid attention to Kari's presentation, it will be extremely unlikely because the RNA only aims to stimulate the immune system of the recipient as opposed to create a virus inside your body that will cause disease-like state. So the way that rubella vaccination or chickenpox vaccination or any other vaccination does not cause male infertility, we would expect that there will be no impact upon sperm production. Yes.
Kari, would you like to comment on this?
No, but I would like to come back on the question from Edgar, if I may.
Yeah.
I've been looking at the Janssen vaccine and what the European Medicines Agency says, and they say under pregnancy, there is limited experience with the use of COVID-19 vaccine Janssen in pregnant women. Nothing in the animal studies, but then they conclude administration of COVID-19 vaccine Janssen in pregnancy should only be considered when the potential benefits outweigh any potential risk to the mother and fetus. So there is experience definitely in the US with the messenger RNA, and in Israel. Israel had around Christmas time, I think 60 pregnant women in intensive care when they started discussing to vaccinate, and they have had the Pfizer vaccine available to them. So they've been able to follow. So that's what I wanted to add. Thank you.
Okay, thank you. And Vicky, you want to say something?
Yeah, I was just going to come in and tell you about 2 studies that have been done on sperm parameters before and after COVID vaccination. And these are preprints, so they haven't been through peer review. And again, they're experiences from single clinics, so reasonably small. But basically one of them wasn't clinics, it was just they recruited students before and after they had their vaccination and took a look at their sperm. And they found no difference in how good their sperm was before and after vaccination. And then the other one has been done in the context of a fertility clinic in Israel. And it looked at people's sperm parameters from last year before there were any vaccines, and it invited them to come back and give sperm again, and the sperm looked the same. And this is quite nice, I guess, for fertility patients, because these people were having fertility treatment. Half of them were having fertility treatment because they had low sperm counts or problems with their sperm, and half of them were having fertility treatment because there was something going on the woman's side of the equation. And whether it was a sort of male factor problem or a female factor problem, when they came back and looked at the sperm again, the parameters looked really similar. So hopefully that gives people a little bit of reassurance that vaccination is not going to do anything to their sperm if they're worried about that.
Mm-hmm. Well, that's good to hear. We have some questions that are basically about the same issue. Just a minute, I'll check it from here. One is, if you are in the middle of IVF treatment and have the opportunity to get vaccinated, should you do that now or wait? And there was another about the same issue. I'm 37, about to start ESHRE. Today I received the first dose of Pfizer. Second dose is planned for 27th of July. Shall I postpone the ESHRE treatment till after 37th of July?
Yes, I think we answered these questions in the first question, and our advice will be to have the vaccination and postpone the treatment.
Mm. Very, very short answer. Oh, yes, this is something that we have also been asked in my association. If you get the first vaccine before a pregnancy and you find out you're pregnant about 2 weeks later, is it smart to wait to have second vaccine after 12 weeks?
So is the question there, should you get the second dose or what? Oh, after 12 weeks of pregnancy?
Yeah.
I can answer that, but actually Kari's the one here who's doing vaccinations in pregnancy, so I will leave that one to her.
Kari, do you have
I would discuss with the clinician responsible for the clinic, and I think you probably have to go rather high in the hierarchy and see if you could get the vaccine after, if it's Pfizer 3 weeks and 4 weeks after Moderna, to get it over with. 12 weeks is a long time to wait, I think. It's more psychological. I mean, you want to get started, I presume.
Mm-hmm. And there is also a comment, but what if you cannot postpone treatment because you are in the middle treatment? So basically your answer is for these two, that you should get the vaccine anyway. correct? Am I correct?
I really wish there were a center of excellence in each country that would take these questions. I don't know if they exist. Almost all countries in Europe have what they call National Immunization Technical Advisory Group. And if I was responsible for a fertility clinic, I would approach the chair of those expert committees. They have experts from all kinds of fields in these advisory groups. So there are virologists, there are pediatricians, there are gynecologists, and have a serious discussion. So there is one plan and one guideline for the country at least. Otherwise it will be very complicated if you have different guidelines in different clinics. But they exist, such NITAGs, and they are usually hosted either by the Public Health Institute or by Ministry of Health in each country. And like Germany, the name is STIKO. In Ireland, it's Karina Butler who is the chair. I don't remember the name of the committee. In the UK is JCVI. So they have national names, but the international term is National Immunization Technical Advisory Groups. And it would be very good to have this discussed there.
Yes. And then there's a question to probably Edgar, because you are a member of ESHRE COVID group giving instructions. So my clinic does not ask for a PCR test before embryo transfer. Should there be a protocol for all clinics and hospitals in Europe?
The guideline is on the ESHRE website. This is not a rule, it's not a law, it's a guideline. And clinics have no immediate obligation to obey a guideline. Firstly, you have to remember that each country has its own, as Kari said, has its own protocols for vaccination, but also for screening, testing, identification of potentially infective individuals. Yet the protocol that I've showed you there in relation to patients doesn't say that you have to test after every or at every moment in time. It only says at entry on the program, if you're vaccinated, if your screening test is negative, if your questionnaire is negative, proceed to the next level. And if again you're low risk and you're low risk and you're low risk, you can move on. But if the questionnaire changes and you've been in contact with somebody, you traveled, the last person you met 5 days ago has been diagnosed with COVID, now you have a positive questionnaire, and now you have to have a test to be sure that you don't have COVID, or if you do, then to stop the treatment, or if you don't, then proceed to the next level and have the further questionnaire. So I think you need to discuss it with your local clinic and say, how do you implement a safe environment in your clinic, and what rules do you follow? Make it clear to me so I can understand that I'm attending a place where you take this seriously. And I doubt that there are any clinics that will neglect this aspect of care. Firstly, they couldn't do it because the local government will force them to follow certain protocols. Yeah.
Yes, absolutely. Thank you all speakers. Thank you for joining and sharing your knowledge. Thank you for all the questions from the participants. You will get the feedback request afterwards, all those who were following this webinar. So we ask you to use that opportunity to give your feedback, and we really appreciate your opinion. Thank you, Kari. Thank you, Vicky. Thank you, Edgar. And thank you, ESHRE, for making this webinar possible. I'm sure we might even put these questions and short answers on our website, at least on Fertility Europe's website. So thank you for all your expertise answers.
Thank you,
Thank
Sat.
you
It's a
all.
pleasure being here.
Thank you.
Thank you, and have a nice
Great.
evening, and
Likewise.
goodbye.
Bye-bye.
Goodbye.
Thank you. Goodbye.